Graham has tasked me with the opening. So it's lovely to see so many faces, including my former chair, Susan Moffat-Bruce. So welcome, Susan. It's great to see you again.
Nice to see you.
So, so as everyone, well, probably not everyone knows, I run a small network called the Canadian Health Leadership Network, better known as WHLNet. And we're co-hosting the webinar today with Leads Global. So I want to begin with a land acknowledgement. So we're hosting
Kelly, co-hosting with the World Health Leadership Network, which Leads Global is underneath.
Okay. Thank you, Graham, for that clarification. All right. So we're hosting today from Canada on the traditional territories and ancestral lands of the Indigenous, Métis, and Inuit peoples of Turtle Island. I invite you to take a moment to reflect on the lands from which you're participating from around the world and pay respect to the earth that nourishes life. Let us reaffirm our commitment to forging culturally safe, inclusive, and respectful relationships in our pathway towards reconciliation and the betterment of the planet itself. Please also join me in acknowledging the indigenous culture of knowledge sharing that leverages our collective experiences and allows people to learn from one another in a safe space. It's in that spirit of mutual respect and collaboration that we come here today. So as many of you are aware, the World Health Leadership Network is a concept born from the experiences of the Canadian Health Leadership Network, a network that began in 2009, 2010. And a guiding coalition has been working hard on how to operationalize the World Health Leadership Network now. So lots has been done. We've had our first meeting in Vancouver almost a year ago to the day. They've been discussing the financial stability of the network, growing the membership, the recent workshop at ISQua that we're going to hear more about. And so what began really as a handful of countries, Graham has told me is 14 or 15, many of which are on the call today. So I'm very excited about this. So again, welcome. And that's it from me. And I'm going to turn it over to Kirsten now.
Hi, everyone. Welcome to the webinar today. Thank you very much for taking the time from wherever you are in the world to join us. We're going to have a sort of short introduction shortly by Anurag, who is going to introduce himself then to set the scene, basically, for our session today around systems leadership. And he'll be joined by 4 panel members that you will have an opportunity to meet further in breakout rooms. We're going to have 2 breakout rooms, each of 25 minutes, and you are going to be very welcome to contribute to the discussion, share your experience, share your perspective from your country around systems leadership in improving quality and safety. So this is a very interactive session. We've deliberately made this invite only because we want to have really thorough conversations within small groups. You'll be divided into 4 different breakout rooms, and they're each called different names after geological systems. I thought let's keep the theme of systems leadership for this and have systems throughout our breakout rooms. It doesn't mean you need to speak about the geological systems. It's just there for a name. Each room of the breakout rooms is going to have a facilitator and one of the panel members, and you'll get to engage in conversation with them about this very important topic. After 25 minutes, everyone will be brought back together very briefly before we sort of shuffle you into the second breakout room. So you'll have, hopefully, over those 2 25-minute slots, really good and interesting conversations and meet some people that you haven't actually met before. So we very much encourage you to fully participate, and if there's any technological issues that anyone has throughout this webinar, then Grace is here and you can contact her directly. Yep, she's waving now. So she's on hand to help with any technological issues that you may have. I'm now going to hand over to Anurag, who is going to set the scene for this webinar.
Okay, thank you, Kirsten. So I must start by saying that when we were getting ready for the ISQua workshop in Turkey, and I'm going to take the name, I had a conversation with Dr. Moffat-Bruce. And we were thinking, the title of the session was, translating systems leadership into from principles to actions. So during that conversation, it emerged that, well, do we actually have a shared understanding of the word systems leadership? And how are we starting that? So that's where I started looking into, what is out there? What do people understand with that? And it emerged that people have different understandings of that word systems leadership. Uh, what I was able to garner, and of course, we shared that with the participants, and there seems to be congruence of understanding, is that it really is a collective effort, and it is working across boundaries. So it's a collective leadership, concerted effort of many people working together at different places in the system and at different levels crossing boundaries. So it's a very high level view of what it looks like. There is a healthcare adapted definition of systems leadership too, which really talks about the local leaders across the healthcare sharing a cohesive approach and working together to improve care and the system itself. I'm going to say one more thing and then invite some of the panel members who were at the ISQua meeting to share some of their insights. So the principles around systems leadership happen to be, well, people do have the ability to see the larger system. They can foster reflection and generative conversations. And they're able to shift the collective focus from local problem solving to co-creating the future. So those seem to be some conceptual, broader notions around systems leadership. So with that, I'm going to invite some of the panel members from the ISQua meeting to share a couple of their insights. And if anything is left, then I'll share one as well. So Peter, can I put you on the spot and ask you to please share one or two insights?
Yeah. So one of the things we did in the fishbowl is that we had the opportunity to speak to each of the presenters, and the group in the fishbowl. We have to ask questions. So I've written my one pager for that. So I'm just going to read my summary of it to you, which gives you the key thing, is that we have to change from linear thinking into streamlined and complexity analysis. And this may mean that you might have to, the question is, do you muddle through or do you streamline the complexity? You need to build self-awareness with reflexive leadership and reflective practices being part of your daily work. You need to move out of comfort zones to adaptive approaches to complexity, so you'll be able to adapt rapidly and aim to build and restore trust at every level.
Okay, thank you. Stuart, you want to go next?
Hi, all. My name's Stuart Studixon. I also was a participant at the ISQua Conference. Similar to Peter, we had a really robust discussion in our fishbowl. It was a really vibrant discussion around the different aspects of systems leadership from a whole bunch of different countries. And, I think what struck me the most was much of what you've shared before there, and your egg, around the importance of personal practice related to understanding the context that people are within, and then engaging with all sorts of people across various networks to define the problem and work together to co-design solutions. And when I kind of think of like some of the lessons that I've learned and take away from that myself, from that is the importance of those interpersonal practices, such as open-mindedness, self-awareness, empathy. They're really important to engage with the resistors in the system, to understand the different perspectives in the system, to try to bring those different perspectives together to kind of co-design what the solution could be and what the vision is that we're trying to create. I also think a lot of those interpersonal and personal practices, those self-leadership and engage others practices, help us understand the context, which is so important in building those collaborative networks and creating that co-designed vision that we're trying to get to, or problem definition. And when we get into those contextual factors, you're looking at things like, what hasn't worked in the past? What are the parts of the system that are incentivizing it working in the way that it currently is? How do we use some of those interpersonal practices to understand and maybe shift those and create that more positive outlook for folks to pull them out of maybe past practices? So anyways, it was a very rich discussion. Those are some of my personal reflections and learnings. And similar to Peter, I kind of summarized what a lot of the conversation was within our fishbowl.
Yeah. Thank you. Thank you, Stuart. Graham, I don't see Dr. Agarwal here. So I think we're going to move further. So
you need to share your thoughts now.
Yeah, I'm going to share a couple of things here. I found the day very engaging and very rich, Stuart, as you said. A couple of thoughts I want to share are, one is something Dr. Braithwaite highlighted, which really was around that it's not about processes or hierarchy. It really is moving beyond those, which then creates a bit of a problem for implementation. You know, how do you do things if you're going to be doing in a complex environment where you need to go beyond processes and hierarchies? And he highlighted that perhaps, you know, you should be focusing on the relationships and what he called nested networks. Now, that's what you should be focusing on in trying to move forward. Dr. Siri Wig, she actually took it one step further and said that you can think of systems leadership as a mindset, but it's got tools. So both Dr. Braithwaite and Dr. Wig were able to highlight and identify some tools which could even be used digitally to foster reflection and dialogue, and so take some principles into concrete actions. So really, it was about creating space for reflections through digital tools. And Stuart, as you said, understanding perspectives of others in real time to take it to front level actions. I will not go into what Dr. Ulfat said, because that really defeats the purpose of this seminar, because those were like concrete things that you can do on the front line. So that's where we were. I don't know, we have some time, Graham. So if there is anything anybody else wishes to add at this point, otherwise, Kristen, back to you.
I'll just add one point if I may, and right, Dr. Braithwaite, who was in Istanbul, talked about the process of what he called, what was used there was the fishbowl. And that was a dialogue creating environment, which to some degree we're trying to replicate today. So we're now finished talking at you. And what we would like to do is to put you into breakout rooms and hear your perspectives on what systems leadership means to you, certainly in the context of quality and safety improvement, either nationally, as was laid out in that 2030 action plan that we shared with you, or in your particular role. And each of you have a unique and special and very different role in whatever country you're in. And certainly your country gives a really different context for each and every one of you for the application of systems leadership.
So it seems like we have a diverse group from all kinds of different places around the world. That's fantastic. And I think maybe we'll get some great answers to the question that's been posed to us, which is basically, in your country and in your role, what sort of systems leadership practices could we or have you employed that are really appropriate or that we could basically steal from you to improve healthcare, to improve the health of the patients that we work with and their safety in that particular population. So the idea is to go around the room and have each of you just basically tell us from your perspective. And so if we go in sort of the same loop, maybe that would be the best way to do it. Just spend a couple minutes and then we'll get into discussion. So if I gave each of you about 2 minutes, how does that work? Okay, I got the thumbs up from Kelly.
Does that mean I'm first?
Yeah, it does actually. I'm going to take a bunch of notes here. So Kelly, you're the ringer, right?
So it's interesting, this question, because as a network, our context is a little different because we don't directly provide patient care. But I will come back to, we've been having recent conversations around building Indigenous health leaders across the country. And we have a team together that's looking at this. And it's a combination of colonial, it's a two-eyed seeing perspective. It's a colonial perspective versus an Indigenous perspective. And I am beginning my journey on this very much so. But what I've learned to date is in building that trust to begin the systems thinking and going forward, compassionate leadership is a big piece of it. And what I'm learning about is that you need to create those connections before conversation, before you begin to do the systems work going forward. So I'm learning a lot about more about reflection before you jump into doing your mapping exercises and all those kinds of things, and understanding more of a strengths-based approach as you look at systems thinking, rather than, because every individual in your team is different and they bring gifts to the table, and using that more as you go forward. So those would be my reflections from that early work, because I think we approach this from a very colonial settler perspective, and I think that there's lots that we could learn going forward. So I will pause there. And I'll throw it to Gabriella because she was second, or are we just freestyling now? Cameron, how would you like
Let's go around and do like 2 minutes each of us, and then we'll get into the freestyling. And
Okay.
I think I might have been next. Is that right?
Yeah, I think so.
Okay. And then Gabriella, you'll follow. Because I cued you. So that Kelly, that really resonates around sort of the relationship-centered leadership. And so that's, relationships between healthcare professionals, patients, families, communities, as well as learners. So that broad context, I think. So I think of it, because I know some people had mentioned patient-centered. In my world as a pediatrician, it very much is both patient and families, because often the patients won't be able to speak to their health issues in my context. And what my growing understanding is really the value of community engagement in this space. And so then that sort of leads me to think about, really co-leadership. And so Kelly, you mentioned Indigenous groups. So one of the things in my province of Manitoba, which is in the center of Canada, for those who don't know, at least geographically, is that we, during the pandemic especially, one of our strengths was from a systems leadership was to actually have our Indigenous leaders and community leaders, so both the academic Indigenous leaders and the community elders and knowledge keepers, really taking the lead on what healthcare would look like over the pandemic for their peoples and their communities, which meant that a huge difference in how COVID impacted Indigenous patients, who are, I guess, at least to COVID, one of the most vulnerable populations in our country. And so we saw, much better outcomes than could have been anticipated because of that, as one metric amongst many, but really showed how a more distributed leadership model and really true co-creation could unfold. And so I'll pause there and pass on to Gabriella.
Well, thank you very much. I was thinking that in Chile we are facing a lot of challenges in terms of improving our healthcare system. But we are facing a very interesting challenge, which is implementation of a national strategy of integrated person-centered care for persons with multimorbidity. And we, as a university, I work specifically in the Department of Family Health, or Family Medicine. So we are supporting this process at a national level through training leaders at different levels of the systems. And what I have learned is that it is very important to leaders have a really strength-based approach. So put a focus on resources, on what the teams really do well, and not just what are the difficulties or debilities. So I think that is a very interesting learning that I have in the recent years, and also the talent to engage everyone. I think that when we work in this broad change at a system level, where this system leadership is very important, it is a challenge, but also a very relevant thing to engage everyone in this change. So everyone who is in part of this change, not just the people that is in the core team that leads or implement this change. So I think that is very challenging, but I think it's very important. And as you mentioned before, I think that is very important to involve people in co-design of the intervention and the implementation strategies, and also that they feel that they can have an opinion in this change process. And I think that is, and also I used some words that was mentioned in one of the texts that you shared with us before this meeting, that I think that leaders need to set the tone and this tone of collaboration, engagement, strength approach. And I think that is a very interesting thing too.
Great.
My English is
Thank
not
you.
too well, but I'm trying to be.
No, there's a reoccurring theme that I'm seeing between the three so far. Peter, I think you were next, but we're going to skip by you because you're the other ringer in the group, and we'll move on to. Sorry, who did you pick last time?
Annika.
There we go.
Yes. So I think I just want to really agree with most of what people have said. So coming from the perspective of the United Kingdom, obviously, we know about the integrated care system as they move away from just centering care just in the NHS, to bringing people from the public sector, from the social care sector. And I think one of the recurring thing there is, how do we get system leaders or individuals operating at a system level, especially within healthcare, to be open and willing to work beyond boundaries? How do we get individuals who have really lived their lives working in the NHS and in the NHS systems of hierarchy? How are they able to be open to work, beyond these boundaries, to work with people from the local government, to work with people from the social care sector, to work with people from public health? How do they open up themselves? And also this idea of being receptive, to ideas beyond healthcare. So those are some of the things I think systems leadership, we really need to think about and think around it. And also, how do we reframe outcomes? Because we know within healthcare, outcomes are basically, quality of life, for instance, clinical effectiveness and the rest. But when you begin to go outside of that, you're looking at public health, you're looking at social care, you're looking at the police. So how do we reframe the outcomes so that we have a collective language around outcomes, within a place or a neighborhood or a system? So those are some of the, I believe, challenges and some of the conversations that needs to be had.
Thank you. Mark, I think you were next.
Yes. So what I wanted to share with you is, my experience over the last year since I took on my new role as the Regional Health Authority CEO. And I was given a mandate from the get-go to basically improve health of a subpopulation in that area of Quebec I'm working in, with what I thought was a great toolbox, because in Quebec we have fully integrated system by which all health and social services are integrated under one authority, which gives us quite a bit of levers, I guess, to influence the system, if you will. But to quickly realize after a few months that there were many levers I didn't have, because many of the issues I was exposed to, complex issues like homelessness, for example, poverty, the issues of giving access to care and basically managing the health of indigenous people, all of those required way more than what I had control on. So I realized quickly that I had to build a system around my own establishment in order to do better, to do my job, basically. Meaning that I had to connect with many community leaders, elected ones, but also non-elected community leaders, including community organizations, some that are publicly funded, others that are charity-based. Obviously, other government organizations that are in the area from all three levels of government, municipal, provincial, and federal. And obviously that complexified my world, I guess, in some ways, which what I thought was very simple and fairly encapsulated initially became a, more of a challenge. But I really see now the impact I could have by playing or by trying to influence, I guess, those external partners in order to do better from a health perspective, trying to play on those social determinants of health, and trying in the end, I guess, to improve the overall health of the population, not only the one that I can reach out to, but also the ones that more partners can reach out to. Because that's the case for many of the subgroups, that they just don't have access to care because they don't have the means to drive to care, for example, or the means to even pay for care, because there's a cost just to pay your parking, for example, to go to the hospital. So all of that opened a new world of opportunities for me, and realizing how much that system suddenly becomes way more complex, and what role I can play in trying to move that system towards better health in the end.
Great, thank you. Sam, jump right in.
Down to me now. Okay, so I'll talk on behalf of some of the challenges everyone knows in the healthcare. But I think in Saudi Arabia, it's a little bit unique with the kingdom's direction towards having a unified, totally changed system for healthcare for the Vision 2030. And I can tell, working in the healthcare for over 20 years, I can tell the difference and the paradigm shift. When we used to have all our healthcare services as free services, and we were funded and supported financially from the government totally. So money was not an issue for many years. Now the whole paradigm has shifted, and you can see the challenges. And I totally believe in this session because usually the key element is the leadership and how they handle the changes. Because if you are used to a fund and you used to have a very big budget where you can spend everything, and suddenly you are accounted to what you're spending. So this is a very challenging area, very challenging role. I believe in leading by example. Leaders have to be adaptable, and they have to be able to also develop strategies bottom up, because when you have a big change and the change is on a cultural level, it's not easy to accommodate everyone. So it has to be built not only from direction level, because everyone knows when you have a kingdom or national level goals are set, but how you will meet them, this is the tricky part. And here you will find the pitfalls where many people will fall, that how I will apply and adapt it. And the same applies, this is from a macro level. So I will talk now from a micro level in my institution as well, because we are an academic institution. So in the Kingdom of Saudi Arabia, we have Ministry of Health, which provides care, non-Ministry of Health, which is academic and military hospitals. And then we have the private sector. And we used to have non-healthcare practitioner as presidents to the university, and they were non-healthcare. So the leadership style was delegation. So the hospital was delegated under the Faculty of Medicine to design and do everything. And suddenly you have a healthcare practitioner in-house leading the organization, which is a very big change and shift. So there are some challenges, especially when you have a big change when it comes to financial, human resources, restraints. The good thing about if you cannot measure it, you cannot improve it. And I'm a big believer in data collection. It has to be there. You have to have benchmarks, targets. It have to be reasonable. It has to be based on outcomes and a direction towards preventive care instead of just treatment. We used to have everything treatment. If you have a flu, you go to a hospital. So now if you have a flu, you have to go to a primary care instead of just overwhelming the secondary and tertiary care hospitals. So yes, it's a very big topic, and thank you.
Great, thanks. Peter, any sage words on the topic?
Yeah, just on reflection, to me, leadership's about how you use your power as a leader. Because leaders are granted power and they can either use it well or badly. And what I'm hearing is that that if you don't have a relationship with the people who you lead, you'll be using power badly. And if you don't interact with the different aspects of the care, you'll use it badly. Now, unfortunately, leaders in the current healthcare paradigm, and I'll just use the example of what Hussam said. He said primary, secondary, and tertiary care. That's a design that we have constructed. It doesn't have to be that design. For the person who we call a patient, who sometimes becomes a patient, they're not interested in primary, secondary, tertiary care. They want to get the care where it's the most appropriate for what they need. And we had designed it in such a way that they can't do that because there is a lack of trust and a lack of respect across the different paradigms that we've constructed historically. So I heard the word colonial a few times, and that is because the way you have healthcare in Canada is because of a colonial construct from England, which is based on a very hierarchical position of how healthcare is designed. And this is still what's happened. And I listened to Saudi, I suppose it's a combination of England and America in the way it's constructed. And when I listen to the NHS, and the NHS has struggled to integrate care because they can't integrate care if the money doesn't follow the integration. So that's the bottom line.
So what I'm going to do is I'm going to pose a question to all of you. And I'd like each of you to have an opportunity to answer the question, and then we can do a free flow dialogue where we can ask each other questions to stimulate conversation, and also just see the diversity in different cultures and different countries of how we're approaching systems leadership, especially around the topic of quality and safety. So I'm just going to post this question in the chat so you can all see it. So the question is, can everyone see that question? In your country and in your role, what systems leadership practices are used? So we want to go from thinking about theory into actual practice. What are you actually putting into practice to ensure that action is taken to improve quality and safety for your populations? So when you think about putting that theory into practice with systems leadership, what are you actually doing? Matthew, what comes to mind for you when you hear that question?
It's a good question. And just to give you a small background, a few months ago, almost 1 year now, we just published in one of my affiliated university a study where we do a broad research across Belgium, where we find that each year the Belgian healthcare system kills more than 4,000 people each year. So there is more than 4,000, not 100,000 people each year as avoidable death. So this is the background in Belgium, and it's the first times since many, many years that we really have numbers in Belgium. And we publish it, and we spread it to the authorities, to the government, to the press. And on that background in the press, it lasts 24 hours, and then the journalists go to another subject. No reaction from the public.
Wow.
We go to the government and the authorities, and the only reaction they had was, it's annoying because now we know. Yes. And then, yes, it's annoying because at one point could us be accountable, or what can we do? So we will be back to you. 10 months after, no one react on this terrible study. Not the public, not the government, no authorities, etc. And in terms of leadership, we don't use for the moment any systematic system leadership across all organizations. Belgium is a very fragmented country with at least 3 official languages, with 9 ministers in charge of part of the health, and all those competencies just overlap each other's. So we try in my organization, and we have worked with Graham on the LEADS framework to try to put this in place. But for the moment, we don't have a system leadership in place. And it's also why we are not able to ensure that action are taken to improve quality and safety for our population. So there is a pocket of action that try to, but there is no whole system based leadership model or framework used, and it's also perhaps why we kill so many people. And it's also in my presentation, it's the topic of my research for the moment, but we will have the conclusion in 4 years. But the hypothesis of the research is based on the previous numbers. We have shown that the region don't have an impact on the people we kill. The accreditation level don't have an impact.
Interesting.
Teaching system don't have an impact, etc. So all those don't have an impact on the quality outcome. So the only option in the hypothesis is context, culture, and leadership.
Well, in what you just, it's fascinating how fragmented it is. And I heard in the beginning, the attempt is to share data, to use data to stimulate some systems thinking. And even though it may not have gotten the outcome that you were hoping for, that was an attempt to have some systems leadership.
Yeah. We try to, but there is no incentive because there is no reaction. Yes, we kill people, and the basic reaction, in fact, behind all this is that yes, it's normal. We are healthcare. We cannot save everyone. Yes, but this rate is just too huge. And the last percentage, and then I see that also Stefan raised his hand, but the last point is we also calculate the failure to rescue. So some serious illness and pathology that happens in hospitals, and that normally we must be able to save people when that happens. Earth failure, infection, etc. And the failure to rescue is in France and many countries between 10 to 15%. In Belgium, it's almost 25%. So this is perhaps the first point where we can see, okay, we need to rescue those people. And it's not the 4,000, so it's apart, but the failure to rescue is perhaps one axis where we can really put some emphasis and try to convince. But we are still in a process to convince at least the government and the authorities to say, this is not normal, that in each country it's between 10 and 15, and we are at almost 25.
Thank you, Matthew. Thank you for sharing that. I'll go to Stephen now.
Yeah, thanks a lot. And thanks, Matthew, for sharing that. Really very helpful. Essentially, I think I'll just give a little bit more background. So yes, I work in Nigeria. I was born, brought up here. And Nigeria is one of those low and middle income countries that is heavily dependent on donor funds. So most of the public health initiatives essentially are driven by donor funds. There is a little to next to nothing that the government essentially invest into health sector response and things like that. And in terms of my role, I work with the United States government. One of the agencies I work for the US CDC. And in recent years, I find myself playing a leadership position where I have to interface with the rest of the United States agency in the country. So managing USAID's PEPFAR office and a lot of other stakeholders. So essentially, it helps put you in this position where you really have to think about leading a whole lot of people that are implementing a whole lot of programs on behalf of the United States government. And what I try to do as much as possible is to think through in terms of, overall, there is really no systemic leadership for quality and safety as an umbrella, but recognizing that there are a whole lot of different paths, people working through the different projects, people working through the different spaces where they find themselves within the health sector, clinical, public health, and a whole lot of that. And recognizing that people are trying to ensure quality and safety within the different buckets, and recognizing that it's important to, one, recognize that those exist. Number two, be aware of the things that people are doing across those different spaces and the data that is available from these little spaces, and making sure that, just like Matthew said, that data is continuously being used. Using data across the different spaces, the malaria program, the HIV/AIDS program, a whole lot of other programs within the public health, and even the clinical spaces.
Stephen, can I just intrude for a second? I want to ask specifically. So using the data to inform, what's an example of how the data is being used to make decisions? Can you give some practical examples of those practices?
Absolutely. One of the key you find essentially, I'll give the practical example of the HIV program. You really want to be able to answer the questions. Are we, number one, delivering values to the clients that are receiving the HIV treatment services in the program? And how are we sure that the services that we're delivering is actually yielding efforts, a result in terms of minimizing or reducing the spread of HIV in the community, and ensuring that those who are living with the infection are able to live a healthy life as much as possible. So those are some of the key things. For instance, I lead the monitoring, evaluation, and data science. Those are the things that drives me in terms of the feedback, the data that we are generating every day from providing services to these clients. How are we using that data to inform decisions? How are we using it to inform policies? How are we using it to also respond to the need of the program? And how are we using that to make necessary shifts in changes that should generally happen to the program? But overall, I also find networking really very important. Networking with a whole lot of people who are trying to do things within their different pockets, letting them know that their voices can be heard, bringing everybody together and say that you're not alone. There are a whole lot of other people, and these are the people, these are the things they're doing, and this is how we can build that space. So we have a WhatsApp platform, we have opportunities to be able to discuss, and some of them are even right there in clinical programs. And so they really find these things really interesting, recognizing that just like Professor Bates, sometimes we'll say that we're all employed to do two things. We're all employed to do the work and also to improve on the work that we do. They really find that.
I'm going to just intrude for a moment. I'm going to ask you to just wrap up. I want to hear from a few more people. We only have about 6 minutes left.
Yeah. Yeah, thanks. Absolutely. So I think that's about overall recognizing that you can always use what you have to become what you need to achieve essentially the results that you would like to get. I think that sums it up. Thank you.
Well, thank you for sharing, and I appreciate that you said it's a lot about the conversation and using the data to stimulate conversation. That's wonderful. Melina, may I go to you? What are your thoughts about this question about in your country or in your role, what systems leadership practices that are used to help improve quality and safety in particular?
Yeah, thank you. Thank you for the questions. It's really interesting, considering that Indonesian people in general, we are collective society. So collectivist society. So collaborative leadership is more practical in our context. Leaders not only as a leader like positions, but they also a leader who can also can engage people. Because considering in the Indonesia context, we really still hold strongly the culture. Not only the culture, we also have another factor. We considering the pluralistic of the pluralistic context of Indonesia. We also have religion. So religion is also another things that also stronghold significantly in Indonesian community, and therefore collaborative leadership is very important for Indonesian people. We also yeah.
And what are some practices by which you collaborate? Can you give an example specifically around quality and safety?
Yeah. So yeah, because I just finished my PhD with the research, probably I will share the findings of what we have. So a physician, for example, who work in because my research focus on underserved area like rural and remote areas. So physician who work over there really needs to taking into account how to engage people. For examples, like we have a high prevalence in incidence of tuberculosis, but then it's really hard to make sure and also to engage people to consume the medicines for a long time consumptions, and therefore physicians who work over there, they cannot really work alone. They really need to engage a local or community leader. And also because we're considering culture also important part, and then community leader need to be engaged, acknowledged, and then they also involve culture. For example, they use the traditional song or poems to promote how important to prevent from tuberculosis, and then the results provide a positive result instead of only physicians and health professionals from primary care. That's what we call as a collaborative. And also considering rural and remote people, they really like to be listened. So to be doctor or in rural or underserved areas, they need to be they need to have a specific capabilities like listening, active listening, and building trust. Otherwise, the underserved community they cannot really open.
Yeah,
Yeah,
it's so fascinating how it comes back to those foundational components of being able to lead self and engage others in the leads framework. To have that systems transformation, without those components, it's hard to engage in systems transformation.
Yeah.
Thank you.
Yeah,
I want to make sure I hand it over to Peter. We have a few minutes, I think a couple minutes left. Peter, what are your thoughts on this question?
Yeah, it's a difficult question, actually. Pardon me, in my career trajectory, I was the first Chief Patient Safety Officer at the Joint Commission International. I was the one who wrote the patient safety solutions for that first generation of the WHO patient safety activities. And so here we are 20 years later, and have we really made that much of an impact? And the answer, unfortunately, is no. And so we have so much more work to do in this incredibly complex industry. As it relates to your question, we're a professional association, mostly focused in on the North American environment, but as I mentioned, do international work as well. And as we try to create the change for continuing to promote better safety, better quality, better efficiency, it really is multifactorial in terms of how we do it. We've got a whole array of information resources. We have a deep set of educational requirements, career services.
Peter, we have only a couple seconds left.
Yep.
I apologize.
I know. And the last piece we do is thought leadership and research.
I see that we're all from different countries. I've noted Canada, Aruba, Israel, the US, and we're different professions, firefighters, nurses, clinicians, scientists, psychologists, neuroscientists. So we have a very diverse mix here. Question is, in your country or in your context and in your role, what systems leadership practice might be employed to ensure that appropriate action is taken to improve the quality and safety of the population or your population? So I'll repeat the question again. And as I'm repeating this second question, please try to, concretize what your answer will be so that everyone has an opportunity to say something. In your country and in your role, what systems leadership practices might be employed to ensure appropriate action is taken to improve quality and safety of the population? So I'll do the calling to make it as efficient as possible, and I'll go around because I'll use my screen. And the first person I want to call on will be Phil, because you're on the first person on my screen on the left side, your right side probably.
There you go. Phil. No problem. Thank you. As I was reviewing the materials for today, I was reminded of one particular article that I think that the paper is acknowledging. This was around the briefing note. And that in particular is Peter Senge's 2015 paper called The Dawn of Systems Leadership. And in that paper, he makes some good cases about the capabilities and the practices, and they seem echoed in that briefing note. So I think there's a nice connection there. I do recommend that paper. It has some practical suggestions. Another one would be, and I'm taking this from the relationship as a structural element of systems, that one of my favorite systems authors, Barry Oshry, says that we need to ask ourselves, where am I in the system and what does the system need? That this is not personal, that much of what we think is personal is actually systemic. And he speaks about patterns of relationship that happen. Overload at top level, vulnerability and we're on the front line to the direction that others make. Middleness when we're caught in the middle. As a client or a patient to our system with our own sets of expectations and so on and so forth. And the leadership strategies that he writes about in his book, Leading Systems, are really quite practical. And it's about lessons from the Power Lab, which was an activity in Boston. So he has some very specific leadership strategies that work in some parts of systems, but not in other parts. So for example, creating responsibility throughout a system isn't a frontline role necessarily, it's a more senior role, just as an example. So he has some very prescriptive strategies there. So I would recommend that, but it begins with a reflective practice question, and thank you for opening that, Stu, around personal practices, is that asking that reflexive question about your centrality to your experience. Where am I in the system and what does the system need?
Thank you very much, Bill. I'll also encourage you, if you have some thoughts, you can also use the chat, the chat box to pull these ideas, because I know there's a lot we might all want to talk about, but we're short on time. So next person on my screen is Susan. Your thoughts. Thank you, Phil.
So thank you for the question. I think it's an important one. And I think what I am going to share is probably the fundamentals of how we lead in such complex and diverse systems. And I think it's about a presence and connection. And there are two practices that I am very committed to, and I make all of my leaders be very committed to. The first is holding space, and I term that listening circles. They're not town halls, they're not presentations, they're clearly listening circles. And they can be small or they can be large, they can be prearranged or they can be impromptu. And I think that that's a really important practice. And I think it's something that takes time, it takes commitment, and one that has to be sustained, regardless of the system that you work in. If you're in the hospital and clinics like me, or you're in some other environment. The second also is that concept of presence and engagement, which is standardized and routine rounding and engagement with colleagues that are doing the work. It takes a lot of time. It's not always done well, and it has to be committed to from every level of the organization, again, regardless of whether or not you're having a good day or you're having a very challenging day. And I would say that those consistency, the consistency in those practices is how we lead, regardless of what responsibility we have, regardless of what authority we have, and regardless of the situation that we find ourselves in, because it changes every day. But those two consistent practices will allow us to lead.
Thank you so much, Susan. Very clear. Then I'll move on to Leslie. Your thoughts, please.
Thank you. Building on one of the thoughts from this morning, or that in your opening around cross-border leadership, and what are the practices associated with that. One of the most telling kind of books that opened and shaped my mind and shaped my career and my leadership practices was back with Rosabeth Moss-Kanter and the Change Masters book. And she talked about cross-border leadership as being kind of the essence of being able to change systems. And the pieces that are most significant here are thinking about cross-border as cross-profession, cross-discipline, cross-diverse views in terms of equity, diversity, inclusion, in terms of cross-cultures, as well as the boundaries between public sector, private sector, and most relevant even to what the conversations that we're having out here today in Calgary around integrated care, around cross communities. And the leadership practice in terms of meeting people where they're at and actually inviting those diverse perspectives into a room, and actually finding the rooms and creating rooms where you wouldn't typically find folks, because that's sometimes making the invisible visible, and including these very diverse voices helps you think about helps the process of discovery in terms of the work ahead. And it's the cross-border leadership practice. There's very few leaders I find that are able to transcend all of those multiple sectors, multiple systems, because the health system, the boundaries are blurring between other industries, other sectors. There is no concrete box of the health system anymore. Of how we used to think about it is completely changed. And if we're going to actually make the kind of changes as leaders that are essential, we have to blur the boundaries even further. And that requires practices of leadership that are in this realm.
Okay, thank you so much, Leslie. So we have about 6 minutes left before this session ends. I want to reserve a minute for Stu, because you're part of that. So prepare what your minute, that pitch in 1 minute. And I would try to accommodate as many people we can to share their thoughts before we get to that last minute. I want to give, I hope your connection is good there, Oren, because you're there in the dark, and it'll be great to hear from you, considering the context in which you find yourself, to share your thoughts on this conversation. And, you know, as concrete as possible, so that we can, before we move on to that last minute.
Yeah, so I'll try to be precise. And thinking about systemic changes, I've had my experience with some more successful than other of trying to create a systemic change in the level of the nation. I think two were successful, and the rest were less successful. Probably what what made them successful is the collaboration we had with the stakeholders, and we invested a lot in searching who are the key stakeholders that has to be we have to have their buy-in in order to manage a successful try at the change, at the systemic change. And I think once we did manage to create a firm collaboration with those stakeholders, then we succeeded more easily.
Thank you so much. That was really precise, Oren. Kudos.
All right.
I have the opportunity to invite one more person before I go over to Stuart. You're making this very tough for me. I see Kirsten's hand up and I see Neil's hand up. Okay, so okay, brief 1-minute pitches from both of you. So Neil, you were first. You go first.
Certainly. I think the essence, picking up on something Phil cited and the Peter Senge's article, 2015 article, one of the most interesting things of the article to me was the example from Nelson Mandela's Truth and Reconciliation Commission. I believe, and this is particularly robust and important to us in the US, truth and communication, trust and truthful information. This is the most serious problem for us socially, politically, health, everything. We have too much misinformation, too much disinformation.
Thank you very much. That was powerful. Thank you. And concise. Kirsten, the bar is high. Up to you.
Okay, well, I'm going to put my points in the chat, but we've been doing a piece of research over here, me and a colleague, with integrated care system chief medical officers to see how they're navigating their new roles and what they're actually up to, how they're enacting those roles, I guess. And some really interesting things have come out of the interviews about what they're doing and what they're finding actually quite important, and being able to sort of galvanize, particularly their clinical colleagues, around a sort of moral imperative, so to activate intrinsic motivation in people to actually.
Oh, I think Kirsten has a connection problem there. So I'll just move on to you, Stu, to wrap up with your thoughts. And Neil, could you kindly put your comments in the chat, please? Thank you. Stu, over to you.
I've got 1 minute still.
Yeah.
Okay.
1 minute and 56 seconds.
Hey, I'll take those extra 50 seconds now. Yeah, I really want to pick up the baton that Neil put to me is talk about my own context and talk about how I apply these. So in Canada, we have, much like the States, we have a vulnerable population with Indigenous peoples. Socioeconomic, social determinants of health, disparities in healthcare and in health indicators mean Indigenous people show up in our in our prison system too often, show up in the morgue too often, and it's a challenge to the entire state edifice. It's the center of a lack of trust in a lot of the programs that we do, and it poses great risks to all of our institutions. And so part of this is working with First Nations governments as partners to redesign what that system looks like. And that's what a lot of my work is. And now to redesign that system requires systems leadership. That means the public needs to be brought along. The public needs to be engaged. We're talking about building communities up. It's about getting through cabinet, talking to politicians, making sure that what they see is going to be reflected in what the opportunities are that we bring. Working with First Nation governments that don't see my government and who I represent as legitimate. And so building that legitimacy through interpersonal relations, trying to get them to understand what their vision is and craft it with them with the view of what the public would also want. All of those require, that kind of rotating telescope of what is the broader system need and look like and what can find traction, and then flipping it over and zooming in to interpersonal relationships, building trust, being reflective, working with the nation, building trust with them through a lot of time and investment, but then also turning around and going back to the public and bringing ideas and options there, hearing negative feedback and working with them to build trust, trying to bring these communities together in pursuit of that shared vision that we craft iteratively together, and hopefully, create an irresistible story for Treasury Board. A lot of that centers on people doing things, but a whole bunch of different people across different spaces doing things together. And yeah, thank you.
Let's change the question I was given and say, what have we done in our roles and in our work in our countries that has been successful? What have we actually implemented that has had a positive impact?
Okay. So I'm Susan Moffett-Bruce. I'm the president and CEO of the Leahy Clinic here in Boston. Prior to that, I was the CEO of Royal College of Physicians and Surgeons of Canada and Royal College International. I think probably what we have done here, and I have done previously, is including patients in all major decisions. That has allowed for informed decisions that are well accepted. They may not be always the decisions that people want to hear, but as long as they know that they're centered around those that are most affected by those decisions. And it takes a lot of time and effort to really have patient-informed engagement that's safe and meaningful to them as well as to the system. So I think that has been true for my past 20 years of my career, that patient engagement has allowed for the best leadership practices and outcomes.
Great. Thank you. Betty, I've met Betty before. I'm going to turn it over to you to have a comment.
Thank you. Good to see you again. I'm Betty and I'm based in Canada. And as someone who was working in the system and as a director of patient and family-centered care, and one of the few that embarked on lean management practices, I have to say that back then, I thought we had a real combination of involving the patients, as Susan said, in value stream mapping of the entire system. So I think the practice of value stream mapping, where you see yourself in the context of the whole system, and then also with the principles of respect for people, had huge potential in creating that distributed leadership. When I hear about system leadership, it reminds me of distributed leadership, giving everyone in the system a chance to voice what is not working. And one of the principles in that was stop the line. Anyone could stop the line if there was an issue of patient safety. And of course, I've left the system since then, but I just remember how remarkable it was and how we uncovered, so many issues from the patient's eyes, from the people on the floor working on the front line. And again, that is how you live that practice. The leadership challenge is to ensure that those voices are heard, that there's no hierarchical, heroic kind of leadership, but it's truly distributed, that we can respect the people who, provide care, the patients who come in, their families who see all these rocks in the shoe. So that is what really came to my mind when, I thought about this. As someone who's working in the system now, I think I'm really passionate about the connection around systems leadership, systems thinking, and leading self, because there has to be a sense of agency and empowerment in leading self to be able to contribute in an effective way in a systemic or a system level leadership. So that's my 2 bits.
Great. That's perfect. Thank you. Neil, I'm going to toss it in your direction.
Thanks, Cam. Thanks, everyone. Interesting question. To the last group, I emphasized the point of the importance of communicating truthful information. So with regard to the way you're posing this, Cam, when I'm thinking about actually having impact, to me, at a systems level, moves to an organizational, but my experience systems level has been the US as a nation, and also at least our perhaps overindulgent belief that the US should lead the world with knowledge, so that when we put knowledge out, particularly in science or healthcare, it should also be something to share with the world. With that in mind, the lesson that I learned decades ago, I had the privilege of working with many Surgeon Generals of the US. The one who had the greatest impact on me was C. Everett Koop, who was Surgeon General in the late 1980s. And the lesson that I learned on the systems level was how important it is to not only clearly, but to make messaging clear and simple. And I'll use a specific example. I had the privilege of being the senior scientific editor of the Surgeon General's 1988 report. Now, the original title was The Health Consequences of Cigarette Smoking, the Pharmacological Basis of Cigarette Smoking. That's what it should have been called. After I discussed it with Dr. Koop, and at the time, the President of the United States in the early 80s and mid 80s had recently been Ronald Reagan, known as the Great Communicator, Koop and I decided that won't be a way to inform the public. So I changed the title. The 1988 Surgeon General's report is not called the pharmacological basis of cigarette, it's called nicotine addiction. That was it. We had 3 findings. Cigarette smoking and other forms of tobacco are addicting. Nicotine is the primary form of addiction in it. And 3, the pharmacological and psychological mechanisms underlying nicotine addiction are comparable to those underlying cocaine and heroin addiction, period. We reduced cigarette smoking in the United States from 55% of the population to now 12% of the population. We have saved hundreds of millions of lives. So to me, at the systems level, and then we also had the report shared and we sent it all over the world. I've done other reports similarly, but I always remember what Dr. Koop told me. The power and importance of clear, easily remembered, easily understood messaging.
Great. Thank you, Neil. Oren, would you care to add anything for us?
Yeah, hi. I'm sorry I'm in the dark here. It's just a parking lot I'm just on the way in Israel, so it's nighttime now, evening time.
It actually looks very artistic, so don't
it
worry.
is. I can move a little bit towards the light, but I still can only my head shines. So I've just started in a new system, and I've started working. I'll introduce myself a little bit. I am a pediatrician and pediatric emergency physician. I did my fellowship in Canada, and then I ran the Israeli National Institute for Physician Leadership, and now I work as a director of pediatric emergency department in the southern region of the country, which is a very interesting medical center because it's the only medical service for half of the country size, which is the only part of the country where people do not live at homes. There's a lot of Bedouin populations, which is probably have a lot of similarities with First Nations. A lot of they live in greater poverty. They live in some of them in third world conditions, and so the medical cases are very intriguing and also very challenging. So there's a lot of system to learn. So the first thing I thought when talking about system leadership is learning about the system. And knowing the system, what the system is. So the system, for example, where I work now is the medical center, but the population around it, the community, which is very unique, especially in our country, and learning who you should collaborate with in order to have any system change. So who you should meet, and then when you learn who should be on board in the system.
Oh, we lost him. Well, that ended suddenly. Deb, we've never met before, but I'd invite you to give your comments.
Let me listen first because I joined a bit late. So because of some network issues. So let me first hear and I will comment at the end. Thank you.
Peter, I know you're running away in 2 minutes. Should I give you the floor?
Yeah,
to make a comment?
Yeah, so I'll just pick up where Susan started, is that in the system, you've got to say, who is the system? We often think the system is the healthcare system, the doctors, the nurses, the administrators, but the real system are the people who seek in care. And they come from homes and families and going back to Israel, to the Bedouins. The system is where they live. And so it's not, the healthcare system is not healthcare system as we think about it. It's far wider than that. So you have to look beyond healthcare. We've just created this kind of monster of a healthcare system in which the people have to go to a hospital to get care when they're living in a community in which they have to receive care as well. So a healthcare system leader has to really understand the wider aspects of a system. So in the last group, it's about ceding power. And ceding power to the people who really know it at different points of the system. And the people, and this is where the work I've been doing recently is mainly with Paul Batalden on co-production and just redesigning of how we can really think about, we can get people who are receiving care, the people who some of the people who we sometimes call patients, sometimes are patients, and the people who sometimes are doctors, and they have a relationship in the system to deliver care. So it's about picking up on some of the other themes that are coming forward. It's about how we build relationships, how we use our power, how we distribute that power in a way that people can be enabled. And mostly cared for is how in the future, particularly with the change in healthcare, I can understand in the past why it was done, but right now, our future is how do we manage chronic care and aging. And that's got to use a different thing. Hospitals weren't built for the elderly. Yet we stick them in the elderly, then we run programs for preventing falls when they shouldn't be there in the first place. And why are they falling? Because of the system that we developed. You know, let's say, if you're elderly and you've got dementia and you go to a system, what happens is that you go to the hospital, we build a system, and you fall because you delirium, and we give you a drug for your delirium, and then you fall. Or you give a drug for, so the system's not built for what we have to do. So my final words are that we have to step back and say, is the system that we have built, very expensive hospitals and very expensive facilities, right for the challenges of the future? And do we really have to think? And that's where the money goes. And of course, the big academic science centers are not going to want to close down. So those who've worked in there, they're not going to want to change. And this is where healthcare leaders need to start thinking very differently about what healthcare is. Not disease management, which is what the system was built for. So when we talk about healthcare leaders, they're really disease management leaders. Healthcare leaders do not work in hospitals. They work across the broader system of society. Disease managers work in hospitals. But that's what we have. That's the problem. So it's really the future healthcare leader has to think totally differently from what they're thinking about now. And that's a challenge for this group, is to say, well, how do we move from the current paradigm into something that is really meaningful for the future construct? So I'm a pediatrician, and the problem I had was that the children that I used to see were chronically ill. I didn't care what they were. So I couldn't, any child with long-term condition, because I was trying to see how they could live healthy lives, not how I could manage their particular disease. I had hospital doctors doing that. But it's really trying to work out how they could work across. How do they go to school? How do they get housing? Deb, when I was in South Africa, working in South Africa many, many years ago, and I had children with cerebral palsy, it was no use treating them in the fancy Red Cross hospital because they were going back to a village where there were no facilities. And how did we manage to enable them? And that's a different system. So the healthcare system, I didn't realize then that what I was thinking about then is not the hospital or facility, but it's where people live and where they do the day-to-day work. But that's my two bits. It's really thinking differently. That's what I'm challenging you all to do. And unfortunately, I've got to go. I'm going to Argentina. My talk is about how you see power and how you see power as healthcare providers and co-produced health, not managed disease. So that's where I'm off to now to give that little talk. So
thank you.
I'll see you again.
Maybe
Thanks very much.
future
See you again.
WHLN topic.
Yeah. Thanks a lot. See you again. I'm sorry I have to leave. I'm double booked. Thanks. Bye.
So let me come in now. So I think a couple of things. Firstly, I think what is so different nowadays of practice of medicine, as you heard from Peter. One issue, I think, the technology. And I mean, obviously, when the technological evolution started in the late 20th century, and our tools before that was predominantly a stethoscope and X-ray machine. And gradually we started shifting. And I think that technology changed our practice. And firstly, it put us in a very difficult position. We cannot use our stethoscope. There are new things coming up. And then the second step started when the AI came in. And AI actually also
Looks like somebody's frozen. Graham, I'll turn it over to you if you want to make a comment for a couple of minutes, and then we'll go into a free-for-all for the last 10.
Yes, but Deb just came back, so that's good.
So that is, I think, the first thing. So the technology, and then the AI came in, and I think we have seen that. I mean, a good example would be our dermatology department. It is completely now revolutionized because of the AI, because we don't really see patients, because we have millions of images that which we match it. And then once it matched, then when the patient come, already there is a diagnosis to a dermatologist. And so a lot of this is now a telemedicine practice, which we could not think of before. So that's the first thing. The second thing what we changed, and I think it is the transdisciplinary nature of medicine. I mean, previously we had a medicine or surgery and etc. Now I'm seeing a gastroenterologist is, there is very little difference between a medical and a surgical gastroenterologist. Both are scoping it and both are doing the same stuff. So I think it's becoming a very different thing. And thirdly, I think Mr. Google is also changing our practice. I mean, I've seen, it's quite irritating sometimes, but the patient comes into my surgery with a thick file of all the information, and the only reasons they come to see me, just for me to prescribe a medicine which needs a specialist. They know actually everything. They know the diagnosis. They did all the blood tests. They did the scan, and then they just need a prescribed script. Otherwise, the medical aid will not pay, and that's only my job actually. Sometimes I was told about one of my colleagues actually. They even write the script for you, how much it needed, and only thing you just need to put your signature. So I think, you see, it's sometimes irritating, but it amuses me. I mean, how, and particularly, I mean, Peter left, but I mean, I found this quite interesting with the pediatric patients. I was told, I mean, I'm not a pediatrician. I'm very scared to practice pediatrics, but the parents are really sometimes very demanding, to say this. And I think, so that practice of medicine becoming is quite interesting. And probably lastly, the managed healthcare organization. I mean, what you practice and what you do, I think a lot of these are divided by the MHOs in many countries, particularly countries like US and South Africa, which is more or less follow the same US system. Thank you. Over to you.
Great, thank you. I think we're quickly running out of time. Graham, did you want to comment?
Yeah, I'll just say one or two things. I mean, one of the most interesting systems leadership ideas that makes a lot of sense to me is a concept of leverage. So when I looked at the WHO action plan with 7 lines of action and 5 sub-actions, there were 35 places where if a leader was to take action, if you like, to create the kind of country that was embracing quality and safety in a meaningful way. So I looked at that and I said, well, where do you start? Where's the leverage point for me as a leader to start? For example, one of those boxes was a healthy and effective patient input. So Betty's point and Susan's point earlier, if you exercise the concept of leverage, then why not also use, and patients are a very important group to leverage for change, then use Neil's idea, which is how do we communicate to patients exactly what's fundamentally important to engage them on, and then to use the big data that we have or should have to be able to pinpoint the areas and the groups of people where we need to make a change. So to me, it's a combination of a variety of things that I've heard. But if you don't have a leverage point, place to start that will start the ball moving with a group of people, then you become paralyzed. And I think that's also a point that Betty was making, that you got to link self to the system. So as a leader, you've got to know your leverage point in order to exercise the agency you have as a leader, the self that you bring to that as a leader. So I found this quite fascinating. Thank you.
So I'd like to just pose a question, same question as before. You've probably been warmed up from the first one. And that's, I'd like you to talk about, we want to talk about shifting from theory and principles into how you're actually putting systems leadership into action. And ensuring that action is taken specifically to improve quality and safety for your population. So I want to sort of hear from you about what practices you're doing to sort of analyze the root cause of quality and safety issues, in terms of how you set goals and have people rally around those goals. And then also what you do to select solutions based on those goals. How do you get from where you are now to achieve those goals around quality and safety? So I'll just call on from some of you if you can give some brief examples of how you're putting systems leadership into practice. Would anyone like to speak first? Maybe you didn't get a chance to speak as much in the first round as you wanted to. Yes, Kirsten.
Yep. Hi. So my connection's a little bit unstable, so let's see how long I last. But I was saying in the last session that we'd be doing some research with integrated care system chief medical officers here in the UK. And what's coming out is really interesting in terms of they're all about quality and safety. They're one of 2 clinicians on the board that are all about improving safety through these new systems. But they're finding it really challenging in terms of sort of what's gone on in the past and how much that actually affects the level of effort and what you need to do to actually sort of, build new relationships, build trust, kind of, create an environment that people actually feel that they're able and willing to actually, engage in. And so some of the practices that they have engaged with, I guess, to do this is sort of really kind of galvanize people around this moral imperative. They use phrases like, but it's the right thing to do for the patient. So when conversations get too much into sort of, well, my contract is this or that, they move and sort of engage people to get their intrinsic motivation. So that's just an example of one of the tactics that's being used by chief medical officers.
Interesting. So bringing the focus back to what, something they can all align around, which is the patient at the center. That's great, Kristen. Phil, I'm curious about your perspective on this question.
So am I. I actually, so a lot of the work that I do when I'm not doing research work is around facilitation. So it tends to be large group facilitation, and I like structures and frameworks to help guide the conversation. So related to systems and improvement, one of the frameworks that I use is from Derek Cabrera in his book, Systems Thinking Made Simple, 2018. And he says we're following 4 rules in our head when we're approaching these types of decisions. And it's very simple to hold on to as a coaching framework or as a helpful exploratory framework in conversations with health system providers. So the framework is called DSRP, making distinctions between identity and other, systems as part and whole, not just whole and not just part, relationships as cause and effect, and perspective from a point to a view. So I take those 4 principles, and he says systems thinking emerges from the interaction of those. So for example, in an organization where somebody is not making a distinction in the context their staff are working in, this group over here being thinly staffed and oversubscribed, underserviced, stress, this group over here having a completely different experience, let's say, well, the leadership strategies land differently in those contexts. So I find that the D in DSRP, helping people see how their contexts are different from one another, is a practical tool that I can bring into practice. There are others that are out there as well, like Bowman and Deal's 4 frames analysis for reframing organizations, exploring the conversation through political, symbolic, structural, and help me out there, human resources lens. So a framework to guide conversations. That's how I approach those as a practical tool. Take a framework, bring it into practice.
Thank you for sharing those, Phil.
You bet.
Fantastic.
Anytime.
What I'm hearing you say is that providing a structure or infrastructure for people to have these conversations provides a container for them.
Well, there's so much ambiguity
Yeah.
when it comes to complexity. At least a framework helps people understand where we're opening the conversation. Where it goes, maybe another matter. But when we take perspective out of that framework, for example, that just begs the E in the Leads in a Caring Environment framework. How do I engage people in this conversation? So my strategies for engaging are really, really important. So we heard Stu Dixon talk a little bit about that too, with reconciliation work in our last breakout group. Yeah, I could go on. Believe me. Thanks for asking the question.
Thank you. Leslie, what are your thoughts? Oh, you're on mute. I know, it's always remembering to unmute.
You think after all these years would be able to do that. So as a standards development organization and an accrediting body, we have levers for change around language in standards and the third-party independent assessments against how are people adopting those. And so from that framework, the leadership standard as an example, leadership and governance, we accredit every hospital health system in Canada across all sectors, full parts of the ecosystem plus elsewhere. And the reason why the language is so important of getting this right is because people are spending time, energy, and resources to meet the standards, to uphold those. And so our work is really, it's so critical to make sure that that work is well informed by the diverse perspectives, by the amazing work of like Leads and others that are helping to ensure that the kind of leadership that we're asking and requiring leaders and hospitals, communities, primary care, you name it. What are some of the common threads across all those sectors that are required, and providing some of that standardized kind of approach to saying these are the things, not as prescriptive, but these are the elements that need to be demonstrated in terms of leadership. And one of the biggest challenges that we're finding now, or not challenges, opportunities as well, is now all the standards are being informed with equity, kind of an equity lens as an example into the language is one of the big shifts in terms of how how leadership is described, how governance, and how the requirements in terms of right down to the concrete practices. So that's the work that we do, is taking the kind of evidence and experience of, in this case, around leadership and forming standards that are then adopted to improve quality and safety across Canada and around the world.
Mm-hmm. Mm-hmm. Well, and then it integrates equity into that conversation.
Absolutely.
Approach to
Completely.
quality and safety. Yeah.
Completely, among other concepts, but that is one that's, really front and center. We've redefined safety to bring physical, psychological, and cultural safety. So that again was another big shift, and it's reflected in standards right to the very specific cultural safety and humility standard that is adopted by, was co-created, adopted by leaders and others. So these shifts really help drive and inform some shifts in behavior and practices that are essential.
Mm-hmm. That's great. Thank you, Leslie. Stephen, you have your hand up, and then we also have Matthew that put some information in the chat from his perspective too. But Stephen, I'll go to you next.
Yeah. Thanks, Hannah. Hope my audio is better now.
It's pretty difficult to hear you, actually, Stephen. Give it one more go. Let's see.
Is it better now?
No. I think I'll go over to Matthew and then see if you can tinker with it a bit. It's just it's like, it sounds like your voice is garbled. Matthew, would you be willing to share?
Yes, and perhaps I will give this advice to Stefan to close the video, but in Belgium, one of our hypotheses is to use the model on which we work with Peter Lackman also to activate the leadership in our system, and it's a multi-dimensional model and mainly focused on soft skills, in fact. And so this model is really focused on leadership and how the leaders can really improve the system. And previously, we've discussed it, and we have this study in Belgium where we just say, okay, those are the hypotheses that are not explaining the how many people we kill in the system in Belgium. And I put this in the chat, you can read it. But really to try to say, okay, it's more something soft, and we are working for the moment with 25 hospitals, and we are measuring if those soft skills based mainly on leadership and focused on leadership are really the one who save lives. And I think to try to make the leaders in the system, CEO, CMO, etc., aware that their leadership have a direct impact on the quality and the safety outcomes are the thing that they must work on.
Wow, so really looking at the individual leaders and their communication skills, all that comes with that, their interpersonal skills, and the ripple effect that has on the patient safety and quality. That's incredible.
Yeah.
Gabriella, maybe please, we'd love to hear your perspective or the impact of what others have shared on you.
Well, thank you. From the university, I work supporting the training of leaders and also the implementation of person-centered care innovations. So I was thinking that one of the important dimensions of leadership, I think, is leading self. It's helping and supporting leaders to be aware of how they impact their teams, how they impact the environment, it is safety or not, and reflect about their strengths and also areas of improvement as a leader. I think that is very important. And also how to engage others. I think that a strengths-based approach and also a collaborative approach, it is very important.
Gabriella, may I just ask you something around that?
Yeah, of course.
Just from a practical standpoint, taking it from theory to action, from your perspective and what you see in your role, what does it look like when a leader is is taking a strengths-based approach to leadership. What is a practical application of that you've seen in your experience, especially around quality and safety?
Yeah. One example is that when they start a meeting with the team, it's like just make a question of what kind of things have been going great this week, or which were your main learnings of this week. So it's like some simple questions in the daily practice that put the focus on what went well in the team, in the work of the teams.
That's great. So even the strengths, not from an individuals, but from the collective even. Yeah. This really reminds me of like appreciative inquiry approach, is what is working well that we can learn from and leverage, and not just focusing on what's broken that needs fixed.
Yeah.
That's great. Wonderful. Anurag, what's coming to your mind as you're hearing this conversation?
I'm going to share actually a very practical example from my clinical world. And so I'm a pathologist. We do a lot of sampling, diagnostic procedures, trying to collect information from multiple sources to put something together for cancer patients, let's say, and the report then goes out, right? So on a very practical and a very frontline level, what we did was we actually put the interprofessional group together. The technologists, the physicians, even the secretaries, who are the administrative assistants who are going to be responsible for releasing the information. And we said, what can people do to make sure that only an accurate report goes out? So essentially creating conditions whereby people could come up with solutions on where they see the problems might be and what the solutions would be, right? So one of the solutions that emerged was that prior to the final release of the information, which is done by an administrative assistant, if she finds any error, even if it's a grammatical error, the report will not be released. The idea here is that everybody is playing a role in creating an accurate report. And so lots of physicians were very unhappy about that. How can a secretary stop my report from going out? And the idea was, well, you know what? If there is a grammatical error in your report, people tend to lose confidence in your report because you don't know what else might be there which has been missed, right? So that's a very concrete example of pulling people together, letting them come up with the solutions, and then making sure that they get implemented. And implementation was a problem because we had to get physicians on board. Anyway, so that's a very practical example of what we did.
Well, it also sounds like having sort of shared leadership and empowering those at any level. So getting away from, I think it was Graham, I can't remember if it's you, it was Graham in the beginning, talked about it's not about the processes and the hierarchy of having systems leadership.
Right.
Wonderful. Thank you. Stephen, let's see if we can hear you now. I'm hoping your audio is clear.
Try to get connected. That's great. All right, so I just give a practical example. So generally, like I mentioned previously, networking, getting access to people who are doing things in their different places. Generally found that people really are frustrated about their work when things really don't go well. They really generally want to improve, but it's the how. How do they take actions? What do they do? Usually it gets them confused and lost and gets them demotivated. So one of the things I found really helpful is connecting them to resources, facilitating their capacity in quality and safety, helping them to learn, helping them to know what to do, and helping them to apply the lessons they're learning within where they work. Helps them to really move forward to solving a lot of problems and creating the culture of quality and safety within their space. So getting available, accessible resources, linking them to those resources, ISQua, IHI, and a whole lot of them, and bringing that platform where people are able to share what they're learning, how they're learning. Now they're applying those things, really also tends to encourage a whole lot of other people. And so we generally tend to build as snowflakes where people are solving their local problems locally, but using globally available resources without having to reinvent the wheel or having to tell them what to do, because all those things are usually generally available out there.
Mhm. And what did you say? Just I had trouble hearing you with what are the platforms that the practical platforms you're using to share information? What are some examples?
So we'll have the WhatsApp platform. We have a community of practice. We recently kickstarted, so the community of practice extends even beyond Nigeria to other colleagues across Africa. So we have regular webinars where we bring people to share their lessons, to share their resources, to share their experience, and also tend to really encourage people. People work across different spaces, the public health, the clinical spaces, but they are reflecting on the lessons learned either from the webinars or from the resources, online learning platforms shared, and they're able to come back to you to be able to troubleshoot. So this is the problem. This is about the solution that I'm thinking. This is about the approach, and just wanted to have people walk them through the implementation phase in terms of providing their guidance and recognizing that they're not really alone in implementing quality and safety improvement works in where they find themselves. Yeah.
Great. Thank you, Stephen. Kelly, I'm curious about just your hearing all of these different perspectives, and from your role, even within your organization, how do you approach this from a quality and safety standpoint around systems leadership? What are some practical applications that you've seen?
So we're a little bit different because we are a network and our focus is on the leaders themselves. So it's so interesting because in Canada, there's been a plethora of reports on how we need to fix the health system. And we always say leadership, 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 but they're never specific on how do you do it? How do we build leaders' toolboxes for the 21st century? Because we've inherited all these other practices. So I mentioned, and Gabriella was in my group, so she heard this before, but we're looking at Indigenous health leadership. So we're really trying to employ more within the network a two-eyed seeing approach. So it's the colonial perspective in Canada of how we saw things versus an Indigenous perspective that is more strengths-based that Gabrielle spoke about, but also leading with compassionate leadership. And so even within the network, practically, we're really trying to not jump into the agendas in our working and steering groups, but pause and have those conversations around connecting before we begin the big conversations that are the meaty part of the agenda. And it's hard to slow down and not just want to jump into things. And so I'm just beginning my journey with the team that is guiding me from their learnings as Indigenous health leaders. So I'm learning a lot. And I will share that throughout the network. But that was one of the things I really learned, to stop and listen, because it's so important in that relationship building across and expanding boundaries as well. And Matthew, thank you for all of those links in the chat around compassionate leadership, because that's really helpful. And I will share some of those in the network. So thank you.
That's great. Yeah, I appreciate everybody putting their comments and resources in the chat here. But yeah, it's what I hear you say, Kelly, is that connection's at the heart of this. If we don't have connection first and engage in relationship in the context of the doing of systems change, is that we're not going to get very far. So that's so key, that lead self, to having the skills to be able to connect and engage with one another, but not skipping that step. And I can't tell, even in my experience, we jump onto calls, we have an agenda for the call, we get into the business of it without really having that human connection and experience before we do this work. So, and then we can surface some of the mindsets that are driving the work that we're doing. So
I totally agree. And we were getting better at it during COVID, and now we're back to normal practice.
Just charge forth and do.
Very
Yeah.
much. Yeah. Being that whole person.
Yeah. Who has a thought just based on what we're saying, just riffing off of what Kelly just said?
One of my deans formally told me when I took on the job He said, if you have mutually valued relationships, you can solve anything. And if not, you'll be constantly working on the system.
What a beautiful way to wrap up this conversation. Thank you, Anurag.
There goes. The question I want to ask you is, in your country, your constituency, and in your specific roles, what systems leadership practices might be employed to ensure that appropriate action is taken to improve the quality and safety of the population? Okay, so I'm going to repeat the question again. In your country and in your roles, what systems leadership practices might be employed to ensure that appropriate action is taken to improve the quality and the safety of your population? Okay. So I'll be picking, make use of the chat function, the chat box, to share some of your thoughts, because a 1 minute is really short to express what you have in mind. But I'll be picking on each one of us in a linear fashion to give everyone the opportunity to share their thoughts. And please be mindful of the next person so that everyone has the opportunity to share what their thoughts are. Okay? So the first person I'm going to call will be Mark.
Yeah. And I've already put develop coalitions in the chat, because I believe that's the main principle that I, as a leader managing a health system, you know, that doesn't give me all the tools, I guess, to influence health. So I need to develop those relationships with other leaders outside of the healthcare bubble, leaders on more the social system, leaders of communities, like elected leaders of municipalities, for example, leaders in charge of community organizations that are sometimes publicly funded, sometimes not. You know, leaders of indigenous communities, for example, leaders in the schooling systems, because those are the people that, if I work with, would be able to influence health beyond the borders of my own organization. And I believe this is where the money is, I guess, from a social determinants of health.
Yeah.
Up there.
Thank you so much. That's clear. Developing coalitions. Bill, will you be able to share your thoughts?
Yes, very quickly, and thank you, Jamu. My first thought about this is a personal one, and that is, I've always been impressed with Ron Heifetz's metaphor about you need to take yourself off the dance floor, out of that busy work environment, and get yourself to the balcony so you can see the whole dance floor and see what's going on elsewhere, where you're doing the jitterbug, somebody else is doing waltz, somebody else is doing tango. So getting that perspective and doing that sort of purposefully and mindfully, that's the personal one. Secondly, from Canada, we don't have a system. We've got multiple systems, and it's a politicized system. So the only way actually that I could see forward is actually an intentional process for citizen engagement. Canadians individually look at this non-system and say, how come I'm having to migrate the system as opposed to the system migrating around me? So, and one specific policy initiative that's failed over time, but it's worth another try here in Canada, is a crack at healthy public policy, where you look at health, social systems together. And that, just practically speaking, maybe revisiting the idea of having separate health ministries and social service ministries. In Quebec, Mark, as you know, we have the Ministry of Social Affairs and Health. So bring them together legislatively. So that's it, Jamu. Thank you.
Thank you. Awesome. And I like that metaphor or anecdote. Take yourself off the dance floor, go onto the balcony, see what's happening while you're doing your jiggle. Fantastic. Thank you. Next person I'm going to call on will be Minka.
I think I put it in the chat. So just building on what Mark was talking about, I think really the community engagement and with patients and caregivers included in that mix. I think they're often left out of the conversation. And then building on what Bill talked about, I was thinking in that analogy where the meso lens is. So I guess your dance partner perhaps, or the jazz band that is playing. So I really think.
Minka, you again, okay.
Sorry, just saying how we use the different lenses to approach the problem.
Okay.
Thanks.
Thank you very much. And then I'll go over to Peter.
Yeah, sure, folks. You know, I'm going to take a slightly different approach, and that is, we used to say there were 3 generations in the workforce, then we said 4. There are now 6 generations in the workforce in many countries, and they all have preferences. But what unifies them is a focus, a sense of purpose, a sense of mission. It doesn't matter what generation they are in, style differences aside, that when you look critically at the healthcare workforce, there are around and up to 80 different clinical job types. 80 clinical. Those are the people that touch the patient. And so, yes, multi-professional team-based care is here. Yes, we need to get them to focus with what's the purpose, what's the mission, how are we going to do it? And we've got to engage that workforce because the workforce is stressed. We all know about burnout, we all know about anxiety, et cetera, et cetera. But if you can get your workforce engaged with the systems and processes of change, with that mission, with that purpose, then the natural outcomes are safety, quality, efficiency, value, structure versus process. That'll give you your outcomes.
So I think I hear is less actually more? That might be a question.
Could be.
Yeah. Thank you so much.
But focused.
Yeah, focus, yeah. Then I'll go over to Fury. Molina.
Thank you very much. So Indonesian people is a collectivist society. So therefore, I suggest that collaborative leadership, the first one is a collaborative leadership is very important, considering that specifically more than 60% of people in Indonesia lives in the rural and remote areas, and therefore engaging environment for collaborations, particularly in resources limited settings, very important. An ability to create and sustain cooperative and collaborative environment is a vital in this society. And the second one about probably contextual leadership, where a leader who really have capabilities such as like contextual awareness. They really need to have capability to scan the environment, to aware what happens in the environment. As for example, according to my research focus on rural and remote areas. Anyway, my research supervised by Professor Serjamyu. So he knows really well about this. So I also considering the pluralistic context of Indonesia is really important to really understand readers who really understand about the context. Like in a study mentions like it's impossible to divorce flavor from food. So leaders also are inseparable from their context. Thank you.
Thank you very much, Fury. Thank you. And I learned a lot from you. Still am. Then I have Husam.
Okay. So I'll talk about 2 models I noticed in my career. One of the models usually used by leadership is that we have laws, we have regulations, you have best evidence-based practices, and let's build on that. And this doesn't work all the time, just following laws and regulations. Other tool which we found worked much better is first of all having a clear vision, what you want to enhance really, what we call in quality focus PDCA. Some of you maybe know the tool to understand what really is the issue, not just, oh, look at the problem and we want to go there and just collect data without knowing how you will interpret the data. So this is the first thing, get the buy-in of the people involved by enhancing your teamwork. Secondly, understand your client real needs. I'm talking from Saudi Arabia, for example. The culture is different. What is meaningful for you in a healthcare is different than others. Some rich people, they want the facility, they want the bed, they want the amenities, regardless of what is the outcome. Some other patients come prepared, they look at the outcome. So understand your clients and teamwork. Best projects I have been involved in are ideas which came from the frontline staff, not always from the leadership, but the leadership are always, if they will support and they will enforce implementation and will be supportive to the ideas, this always works and you can reach high levels.
Fantastic, fantastic. I see lots of tying in with some of the thoughts that have been shared here today. But before we get to that tying in, and I think Stuart is thinking like, well, I think there's a lot for me to sort of synthesize here from the thoughts shared, including yours personally. Now I'd like to call on Anikan. I hope I'm pronouncing your name properly.
That's right.
Okay.
Yeah, so from the context of the UK, where we have the integrated care systems, we have the NHS, we have the social care, we have public health, we have the police. So there's a lot of institutions coming under one umbrella, and I think there is that need to have a clear and common framework about what outcome means for everybody. Because coming from the NHS, we can understand what outcome means, and someone from social care will understand what outcome means. But when we're looking at it within a system level or within a population, within a defined area, then we need to understand what does outcome mean for us. And just not understanding that alone, but we need to have shared accountability for these outcomes. So it's not the NHS saying, this is my outcome, I'm going to take care of it. And the social care people saying, this is my outcome, I'm going to take care of it. If we are able to define an outcome that we want for a region, then there should be shared accountability. Everybody needs to understand that this is what we are working for in this population. And this is how we hold ourselves responsible. So I think those are some of the things we can do at the front line, to enhance quality and safety.
Thank you so much. Lots of pearls to digest from this group. Well, Stu, I think you're lucky. You've got more than a minute to share your thoughts. You've got about 3 minutes. So, listen to all the contributions and your experience from the meeting you were at in Turkey. What will be the final thoughts? What would be your thoughts on this?
So I might digress this a little bit just because I really appreciated the balcony analogy given before. And we talked about, and I've heard it here, and I do believe this is going to connect back to the ISQua workshop, but there's so much of systems leadership is connecting into the personal practices. And one of those key personal practices is self-reflection, self-awareness. And one of my favorite books that also uses the balcony analogy is William Urey's Getting to Yes. And that's a negotiation book, and that's what I do for my work in the Canadian context. And so a lot of my work is working with First Nation governments, their representatives, working with the public, working with politicians in high-pressure situations, and trying to affect systems change. And what that can look like sometimes is pretty negative negotiation tactics. It can look like a lot of hostility. It can look like, you're trying to build trust with a vulnerable population that deeply mistrusts you and the institutions that you represent. And all of those can be quite emotionally challenging. And in order to be able to withstand the rigors of that and be able to go to the balcony of systems leadership, you need to go to the balcony of yourself as well. And I think this is something, Peter, I think you're touching on when you're talking about the multi-generations within the workforce. But if you can go to the balcony when you're dealing with different people and you're dealing with conflictual situations, or you're dealing with high pressure situations with, a patient coming in, being able to go to that personal space that allows you to look at yourself and understand how you're reacting, to gain control over yourself, enables you to gain that system's perspective as well. Maybe go up to that other balcony. And so that's something that struck me just in hearing this, the importance of those personal practices that really contribute to those strategic systems leadership practices. So thank you all. Very thought-provoking, and I appreciate it very much.
Awesome. And just a quick question for you, Stu. I mean, if you're a retired firefighter, does that mean that you're not a firefighter anymore? I think
I'm not a firefighter anymore.
Sorry?
I was a firefighter for 8 years, and
8 years.
Yeah.
I thought once a firefighter, always a firefighter, but that's not the case.
That's not the case. I mean, in some ways, I will always be a firefighter. I can still know the ABCs.
Thank you so much. So I think this has really been exciting. One of the things that I think what I've heard also in some of these conversations was also, I mean, talking about the generations, being on the balcony, self-reflection. What comes to my mind is should emotional intelligence be part of this? I mean, because I see that tying into all of these different lenses of what you've shared. Does that resonate?
If I can, Jamu, I agree with that. Intelligence, emotional intelligence. What I'm hearing also is agility quotient, not just EQ, but AQ. The ability to respond in real time based on core values, and I don't know who mentioned it, but a common shared understanding or framework or frame of reference based on shared values.
Powerful. Thank you so much.
Thank you. Well, I was part of the two groups, and the discussions were very rich, and the time was not enough. So I think I'm going to invite the facilitators at this point in time to share at least one insight. We'll just do one round and see if there's time for more. Not in any particular order of preference, but let's see whose name I see here first. Okay, Kirsten, you get to go first. And
I did that being a facilitator, Anurag, so you might want to go to someone else.
Okay, all right. In that case, Jamu.
I was scared of that. I'll be called first, and then I won't have enough time to prepare. But anyway, there I go. Thank you very much, Anurag. And wow. I mean, the two sessions I had was like lots of ideas. I've got about 4 pages of notes that I have to sort of synthesize, and you're telling me to give you a summary in. So I think what I would use to summarize everything I heard is the last concept, the analogy of the balcony, but I won't go into details. The point was, it was AQ, agility quotient, and EQ, emotional quotient. Combining both, those are two important competencies that we need to incorporate if we really want to make change happen at a system level. And within those two concepts, is the ability to understand your systems, understand your generations, understand how you're going to collaborate with the different constituencies, how you listen, how you're there for the members of your team, going to the front line to understand what's going on. I can go on and on and on. But I'll just leave it at the AQ plus the EQ was the major takeaway from me from the two sessions I was able to facilitate. I'm sorry if I'm not doing justice to all the ideas and thoughts that were shared. I was really proud that I kept quiet throughout both sessions, because that's very difficult, as you know, just to listen and take notes. And I'll leave it at that, and I'll pass the button back to you, Anurag.
Okay, thank you, Jamu. We probably will come back to you and your group, but let's go to Cameron.
I feel like saying ditto, as in what you were just talking about. Very similar in the groups that I was participating in. The importance of this holistic approach and having diversified voices around the table and shifting where healthcare happens, I think was a reoccurring thing in both groups. And EQ, the ability to understand those relationships, how you're being perceived, communication, etc. Similarly, multiple pages of notes here. But yes, holistic approach, inclusive of everybody, and really leveraging your ability to communicate and the different voices around the table to solve those big problems that we all have in healthcare. And that was kind of my what my notes told me to talk about. So there you go. Thank you.
Okay. So Bivon, Jamie, and Cameron, I'll be coming back to you. So Kelly.
Thanks, Anurag. Well, certainly through the conversations that we had in the two different groups, I think the thing that struck me the most is how important the quality of connection is, and that we're doing this work of systems leadership in the context of relationships, and the quality of those relationships and connection is so critical to coming together to have conversations that are meaningful to create positive change. And so, it really does come back in terms of the LEADS framework to your ability to lead yourself, to have the skills to be able to connect and engage in relationships, and then go over to the engage others, that's critical. Without that, the other aspects or domains of the LEADS framework and the systems transformation can't happen. So those foundational components are critical to this, to the conversation, and all the examples people gave of how they're putting the theory of systems leadership into practice happen in the context of these relationships. So that fascinated me, and it keeps coming back to that.
So we have quite a lot of time for this segment. I'm just going to do one more round, and depending on how much time it takes, we can come back and open it up to the group. But Jamu, and perhaps Jamu and Cameron and Kelly, you could take the next round of speaking to, were there any insights on some practical practices people could do, or what you heard? Whoever wishes to go first, yeah.
I can go first. So I think it was so interesting that there was a diversity from technology practices of like using a WhatsApp app to be able to create a platform for conversation and sharing, knowledge sharing, so that there's to break down those silos within systems to create system changes in quality and safety. But also, so Phil, where's Phil? I'm trying to find Phil. There you are. Phil gave some examples of sort of structures in terms of having conversations and frameworks so that people could input their knowledge and their perspectives and their experiences into frameworks so it's cohesive and organized in conversations. And I think that was another practical example. And there's so many out there, Phil. You mentioned a couple. Phil, do you want to just share the couple that you mentioned quickly? Would you be willing to do that?
Sure. One was the work of Derek Cabrera from his book. His second edition was Systems Thinking Made Simple, 2008. He uses DSRP, ability to make distinctions, see systems of parts and whole, relationships as action and reaction, cause and effect, and perspective from a point of view. And then the other one was Bowman and Deal's 4 frames analysis. It's a very practical tool for some conversations in a robust way. Thanks for the invitation.
Mm-hmm. Thank you, Phil. So I think using frameworks, technology, I also heard that some practical applications is just being able to create forums for people to get together and have conversation, which can be so challenging in terms of the way the workflows are built, is that these conversations aren't often, they're built into the workflows. So although it's a challenge, is when it can happen. Yes, Graham.
Oh, I'm sorry. I didn't mean to interrupt you. Maybe I could speak when you're done.
Sure. So, but just having the frameworks for people to be able to have the conversations can be a challenge because they're not built into the clinical workflows, certainly. any clinicians on the call can kind of probably empathize with that experience. Graham, please pipe in.
Well, actually, I wanted to riff off this a bit because Leslie is here from the Health Standards Organization in Canada. And I know one of the marvelous pieces of work that they have done is to articulate very clearly for people in leadership roles how you might engage patients, families, and communities to give meaningful input into changes that are required. And the materials that they've created talk about, do you want the patient to be involved? Do you want the patient to be a decision maker? Do you want the community to simply be consulted? And they've outlined a beautiful typology of different approaches in each of those different circumstances, depending on your leadership role, actually, in an organization, right from the CEO or board down to the frontline leader. And I just couldn't not put that on the table. And I certainly invite Leslie if she wants to make another comment before we go back to Renreg. You're on mute.
I'm trying to keep quiet, so I mute myself. Just thank you for that call out, and I guess that's at the heart of the bringing people to the table, understanding kind of how that engagement and what that purpose of it is, and respecting and understanding the distinct knowledge that is brought from those different perspectives and that collaboration from patients, families, and we're really shifting from kind of overall that kind of engagement within organizations to much broader social participation. And we've seen with the UN Declaration of Social Participation, how that fundamentally transforms the way in which you engage. And we bring all of that into our standards and practices and resources.
Hey, thank you, Leslie.
Happy to share too.
Thanks. Jamu? Oh.
Yeah, thank you very much. I just did a quick scan of the comments of the two sessions. One of the things that really what struck me was the element of bringing it back to the individual. So moving away from all the technologies and all the structures, but going back to who we are, the core of what makes what makes a system, the heartbeat of a system. And terms like meeting people where they're at, I think that's one of the things you said, Leslie, that I noted. Like knowing where the action is, where you're going to place your bet on. And terms like collaborative leadership and contextual leadership. This was coming from Furi's work from Indonesia. Like when you look at systems leadership and you're looking at more than 60% of the community living in rural areas, and you want to transform healthcare, how do you go about that? And there was one that was really striking that came from the UK, where they said, do we have a shared understanding of what we mean by outcome? And do we take shared accountability for that? Because we all talk about outcome. We all talk about the changes we want to see, but are we talking about the same changes? Is there agreement? And I'd like to invite Bill, because I think it was Bill who mentioned that we probably have to redefine. First of all, it used this analogy of the balcony, so maybe you might want to share that, Bill, but also talk about this whole idea of maybe rewriting or redrafting policies that are more inclusive and not disjointed. I don't know, he's on the train, I know that, but probably can just chip in. No, I think he's lost.
He's on the train.
Yeah, okay. Well, I'll try to rephrase what he tried to say. He was saying that for us to really be able to make a great make significant change, we probably have to take ourselves off the dance floor and go onto the balcony, and then take a peek from the balcony and what's going on around us, and then see, based on what we see. Sometimes we're only busy with all the jiggling we're doing on the dance floor and missing the bigger picture. in which he says that's for us to really, and I think the core message is we need to understand, really understand what the needs are, what's going on, what's working and what's not working. And based on what we're seeing and observing, recreate or regenerate ideas that will actually lead to effective systemic changes. So I think I'm trying to rephrase that in the way I can't use the right words. The way he did it was fantastic. But I think that was one of the main things in which I think is something we can take on.
Thank you, Jamu. I know we still have 1.5 minutes for this section. I'm actually going to go off script, and I'm going to put you on the spot, Dr. Angut, to see if you wish to share anything. You're muted.
Put me on the spot. Yeah, I've put a couple of comments in the chat box there as well, but you know, context, someone heard it a couple of times, context is pivotal in all of this, whether we focus just on safety or quality, or we view it all, and that's where the balcony is coming from in this metaphor, right? It's the context with which we're viewing our systems. And I think that's a big part of what we're dealing with in terms of systems leadership. And it's difficult because cultures are often driven by leadership, and leadership has a hard time getting full inputs from the front line. Several systems in different countries have done the so-called leadership rounds, you know, where the CEO goes around and hits the floors, et cetera, et cetera. But those aren't all that helpful. So we need to figure out how is it that we can create the different types of communication patterns in these systems so that there can be broader context, and so that then there can be an outflow of communication as well as a backward inflow of communication. That helps to create the engagement, that builds the culture, that helps leadership drive the system a little bit better. And so my last comment in the chat was all about value. When you look at value, simple equation, quality over cost. No, it's a really incredibly complex equation based on those 5 different groups and all the variabilities. Even all of us on this room here, we all showed up with right lower quadrant pain, if we all showed up with appendicitis, we would all behave differently and our care would be different. That's only one little way of looking at the varying context. So yeah, we got to think simplistically, but always remember it's a tough, tough system we're dealing with. And that ain't going to change anytime fast. But we got to keep trying.
Yeah. Well, just when the discussion gets to be really deep and rich, we have to draw this to a close. So, Cameron, I'm going to ask you for one last thought, and then I'll turn it over to Bill. Sorry, not Bill, but Graham.
I think my last thought is around healthcare being a complex system, and that we need a collaborative approach to navigate those systems. And somebody mentioned, or a few people mentioned, the incoming technology and how that was a problem. And so if we think about technology can be a friend or a foe from the perspective, technology can be used for equity and access to healthcare systems, but it can also create a problem in equity and access. And it takes a holistic approach with many voices around the table to solve those future problems. So a clear vision of what we want when we're implementing technology, I think is a path to using technology. And that was, I think, one of the things that came out in some of the discussions. And yes, we never have enough time to discuss these things. So.
Right. Okay. Over to you, Graham. On a slightly unfinished note of where we are, but we need to bring this to a close. So over to you, Graham. Yeah.
Thanks, Anurag, and I'm going to do a short closure, everybody, first by thanking all of you for attending, because the international perspective on these issues is so fundamentally important for us to be successful as healthcare leaders on a global scale. In other words, serving our local populations. We need to learn from each other and interact with each other. In the words of Callie said, the quality of relationships are really important. I hope some are built from this conversation today. With that, I just want to thank all of you for joining us today. It's been marvelous.